Thanks, Natasha. Hi, everybody. Thanks for joining me this evening. As Natasha said, I'm Kelly Vile. I'm a nurse practitioner in family practice. I've been in primary care here at Barton for the last 15 years, and I'm currently practicing out of Barton Community Health Center. I see patients throughout the lifespan, so from birth to death, I see it all. And I am here to talk to you tonight about prevention of diabetes, and specifically what you can do through lifestyle and medications for weight loss to prevent diabetes. So thanks for joining me. All right, so here is a brief overview of what I'm going to be covering. I'm going to start out with a basic outline of diabetes, talk about what it is, and then talk about some prevention strategies. And then we're really going to take a deep dive into weight loss medications. And then at the end, I did save some time for questions. But if you do have a burning question, please feel free to ask me. Okay. So what is diabetes mellitus? So plain and simple, diabetes is a metabolic disease characterized by elevated blood sugar in the bloodstream. And there are three main types. Type 1 is an autoimmune disease where your body actually attacks the pancreas, which results in the pancreas not being able to produce insulin. This type of diabetes is not preventable. Whereas type 2 diabetes is preventable, and that's characterized by elevated blood sugar due to the body not using the insulin like it should. And then the other main type of diabetes is gestational. So that's where your body's cells become resistant to insulin during pregnancy. And as you'll see later, gestational diabetes can increase your risk for type 2 diabetes up to 10-fold. So those are the types of diabetes, the main types anyways. But today for this lecture, we're going to focus on type 2 diabetes only. Otherwise, we'd be here all night. Okay. So in order to understand type 2 diabetes, I want to talk about kind of the normal body function. So as you can see over here, this yellow organ here is the pancreas, and that's what produces insulin. So your body has glucose or sugar in the bloodstream, and then the body sends out insulin, which is kind of like the key here that unlocks the cell so that it can accept glucose into the cell and your body can use that as energy. So that's the normal process. In type 2 diabetes, what happens is there's a ton of blood sugar in the bloodstream. So your body is just producing insulin just in very large amounts. And your body cells finally say, enough is enough. We're not taking any more sugar into these cells. So that means that they have become resistant to that insulin. Okay. So that results in the glucose not getting into the cell. And so your body doesn't have that to use as energy. So that's type 2 diabetes in a nutshell. Approximately 11.3% of adults in the US have diabetes, which is roughly 37 million. And the majority of those cases are type 2 diabetes, so 95% of those cases. Okay, so in order to know if you have diabetes, there are various ways to monitor your blood sugar. So you can get a blood test ordered by a medical provider that checks your sugar or your A1C. All right. And then over here in this picture, we have somebody doing a finger stick using a glucometer. So you can use the glucometer to check your blood sugar at any time at home. And then finally, we have continuous glucose monitors. These are really becoming popular these days. Two main continuous glucose monitors that we use in the clinic are the Dexcom and the Freestyle Libre. These are really neat because you wear a sensor and then they sync with your smartphone or reader, and you can kind of watch the trend of what your blood sugar does with certain foods or with exercise. They are available by prescription or over the counter. Okay. So if you go to your medical provider and you get a prescription, insurance typically only covers these if you are on insulin. But if you get a prescription and you want to pay cash, they cost about $75 a month. The over-the-counter version of a continuous glucose monitor costs about $90 a month. The benefit to that is that you don't need a prescription to get those. All right. Okay, so we're going to talk numbers here. So this graphic over here, so if your medical provider ordered labs for you, and you went to the lab in a fasting state, so that means you didn't eat anything overnight, these are the numbers that you might see. And hopefully yours is in the green. Normal blood sugar is less than 100 fasting. High risk or pre-diabetes is 100 to 125. And then diabetes is typically diagnosed when your sugar is at 126 fasting. If you fall into these two categories of pre-diabetes and diabetes, your medical provider is then going to order an A1C to see if you are actually in pre-diabetes or diabetes. A1C is kind of a funny number, but I'll tell you how we kind of figure out what that is. If you look down here, you can see red blood cells. The blood sugar actually binds to the hemoglobin on our red blood cells, which circulate in our body for about 2 to 3 months. So the lab actually looks at the percent of our hemoglobin that is saturated with glucose. And they come up with this funny percentage number that equates to a certain average blood sugar. So here you can see that a hemoglobin A1C is normal if it's less than 5.7. So anything 5.6 or below is going to be normal. Pre-diabetes or high risk is 5.7 to 6.4%. And then you're going to be diagnosed with diabetes if you have a 6.5% or higher. And just so you have some sort of idea of what that means, if your blood sugar is normal and your A1C is 5.6%, your average sugar was about 114 over the last 3 months. Whereas if your A1C is 6.5, your average sugar has been about 140 for the last 3 months. Okay. All right. So here's a graphic of some symptoms of diabetes. And unfortunately, diabetes does not have a lot of symptoms at first, so you may not even experience symptoms if you have diabetes. A lot of these can be later signs, but as you can see here, you might experience increased urination or nighttime urination, increased hunger or thirst, blurred vision, rapid weight loss or weight gain, depending where you are in the process. Some people will develop dark skin around their neck and armpits. That can be a sign of high blood sugar. And then also, if you have a wound that's not healing, that could indicate diabetes. Numbness or tingling in the hands and feet, or even sexual problems can be an indicator of type 2 diabetes. Okay, so I want to go through some of the risk factors that people have that lead them to be at a higher risk for developing type 2 diabetes. Some of these you'll see we can do something about, and then some of them you can't, but it just means you need to be more aware. So if you have a family history of type 2 diabetes, you're going to be at increased risk for developing type 2 diabetes yourself. So if you have one parent with diabetes, there's a 40% chance that you are going to get diabetes. If you have two parents with diabetes, you're at a 70% chance that you'll develop diabetes. So those people really need to focus on these preventative strategies that I'm going to talk about. We also see a higher risk of diabetes in certain ethnicities, including Asian, Hispanic, or Black. Those older than 45 are at a higher risk for developing type 2 diabetes, although we are seeing it more in the younger folks these days, which is unfortunate. Obesity puts you at risk for diabetes. So that means you have a BMI or body mass index of greater than or equal to 30. And the fat distribution actually determines your risk for diabetes. So if you're a person that holds your fat kind of around your midsection, you're going to be at a higher risk for diabetes than somebody who has more fat on their hips and thighs. It's kind of that apple pear thing that people used to talk about. So if your body's more of the shape of an apple, you are going to be at higher risk for developing type 2 diabetes. The following medical conditions can also be can put you at risk for diabetes, including polycystic ovarian syndrome, which is PCOS, metabolic syndrome, cardiovascular disease, hyperuricemia, which means you have high uric acid in your blood, and then, as I mentioned before, gestational diabetes. So those are kind of all the things that you can't really do much about. That's just how you're born. But the following things we're really going to focus on, and that's lifestyle, whether or not you're sedentary, if you're a smoker, you're going to be at higher risk for diabetes. And I thought this one was interesting. If you sleep less than or equal to 5 to 6 hours a night, you're actually more at risk for diabetes than somebody who gets more like 7 to 8 hours of sleep a night. So sleep is really important. And then diet, we're going to talk about that more on our next slides, but there are certain diets that put you at risk for diabetes as well. Okay, so the following are dietary patterns that increase your diabetes risk. First off, that's the Western diet, and that's kind of everything you see in the picture. That can be like red meats, processed foods, sugary drinks, sodas, juices, things like that, that a lot of people here in the US tend to eat. That dietary pattern does put you at high risk for diabetes. And then also vitamin D deficiency. We've found that people who have low vitamin D are at a higher risk for diabetes. So the lower your vitamin D level, the higher your risk for developing diabetes is. I thought that was interesting. And then these dietary patterns, we actually see decrease your risk of developing diabetes. So you may have heard Mediterranean diet. Well, it actually helps prevent diabetes. And the Mediterranean diet is a diet that's going to be rich in your fruits and vegetables, chicken, fish, olive oil, nuts, things like that. Whole grains, if I didn't say that already, nut butters. Let's see. Oh, dairy. I thought that was really interesting. So studies have shown that the lower your dairy intake, so milk, butter, cheese, the higher your risk of diabetes is. So to me, that was a little counterintuitive, but studies are showing that you do need to have some dairy in your diet to help lower that risk of diabetes. And then finally, my favorite one is coffee can decrease your diabetes risk. So if you're a coffee lover or a caffeine lover, you're in luck because 4 to 6 cups of coffee a day are shown to be of the most benefit for decreasing your diabetes risk. Or if you don't like coffee and you're more of a green tea fan, 2 to 3 cups daily of that can really lower your risk as well. So just don't load it up with a bunch of sugar because that'll kind of like reverse the benefit of your coffee and green tea. Okay. So diabetes is a really serious disease. It's not a mild disease at all. It can lead to some really serious complications. You probably have heard of a lot of these. But basically, in a nutshell, the blood sugar kind of goes into your little tiny arteries and capillaries. It causes inflammation. It makes them sticky. They get clogged. Okay. So, diabetes leads to diabetic retinopathy, which basically means that it's damaging the back of your eye and that you can go blind. Diabetes is the leading cause of blindness in working age adults. Diabetes can also cause kidney disease, heart disease, stroke. It also damages the nerves in our hands and feet, which decreases the sensation, which can lead to you having maybe a wound on your foot that doesn't heal, that can eventually lead to an amputation of an extremity. Diabetes is the leading cause for having an extremity amputated due to a non-traumatic reason. So as you can see, it affects a lot of systems, and it's a really serious disease. So we really want to prevent it. And that's what we're going to focus on. So this is an overview of the prevention strategies that I'm going to talk about. We'll review recommendations for exercise, weight loss, smoking cessation, diet, and then finally medications. Okay, so exercise really helps prevent diabetes, not just because, it makes you hot and sweaty, but it also changes the way that your body metabolizes blood sugar. So exercise actually increases the cell's insulin sensitivity. So instead of blocking that sugar from going into the cells where we can use it for energy, when we exercise, it lets the insulin allow the glucose into the cells, and then you have more energy. Also, when we exercise, the muscles absorb up to 50 times more sugar into them than if you were just sitting around. So you're going to be using a lot more sugar if you're exercising. We do recommend about 30 to 60 minutes of moderate intensity exercise most days of the week. And by moderate intensity, I mean that you should be exercising enough to be out of breath, but still be able to talk. So you can see in that picture, those two ladies are probably having sort of a breathless conversation. That's the intensity that we're going for. You shouldn't be breathing so hard that you can't get a word out, okay? So 30 to 60 minutes most days, that equates to about 150 minutes of exercise per week, which is good. 300 minutes a week is even better when we're talking about preventing diabetes. Okay, so weight loss is also a good strategy to prevent diabetes. Studies show that losing 7% or more of your body weight does lower diabetes risk. So for example, if you weigh 200 pounds, you would need to lose about 14 pounds to lower your risk. Okay, we can do that through diet and exercise. Some people go the surgery route and have bariatric surgery where their stomach is made smaller, and then also the medications as well. All right, so why does smoking increase the risk of diabetes? Well, smoking in and of itself will increase your blood sugar. It also impairs the cell's insulin sensitivity. So again, the sugar is sitting out in your bloodstream instead of getting into your cells. And then this is something I didn't know, but smoking will increase the amount of abdominal fat that you have. So remember we were talking about the apple versus the pear? Well, smoking will change your body composition to hold more fat in the abdomen. There are various ways to quit smoking. I listed some of them here. So there are medications such as Wellbutrin and Chantix that you can get from your medical provider. You can also buy nicotine replacement over the counter. You can get patches, lozenges, gum, all sorts of things. And then vaping can also help you quit smoking. This is the only time that I am ever going to recommend that somebody vape, because if anybody knows me, they know that I am like the queen of talking about not vaping. But when they invented vaping, it was actually invented as an aid to quit smoking. And studies show that vaping, that if a smoker quits and changes to vaping, it is actually safer than smoking. So this is the one and only time that I'm going to say that I recommend vaping to quit smoking. Okay. So, which diets are the best diets to go on? I mean, you can search the internet and there are so many diets out there and they all prove to be the best ones. And you can really go down some rabbit holes on diets. But the two that I've put a square around here, these are the only two diets that have been researched and shown to help prevent diabetes specifically. Okay. That is the Mediterranean diet, which we talked about earlier, and the DASH diet, which is also known as Dietary Approaches to Stop Hypertension. Whoever invented that name, that's a mouthful, but I call it the DASH diet. So the thing I found interesting about the Mediterranean diet that's different from the DASH diet is that it helps prevent diabetes with or without weight loss. So somebody who's eating a Mediterranean diet, even if they're not losing weight, this is going to help you prevent progression into diabetes. Okay. Both of these diets basically recommend a lot of fruits and veggies, those lean proteins like fish and chicken, nuts, olive oil. I think the difference with the DASH diet is that they do recommend the dairy in there as well, so low fat dairy. The keto diet is all the rage, was all the rage. But unfortunately, there is no evidence that the keto diet does help prevent diabetes. So I would definitely avoid that diet. It's really hard to do correctly anyways. So I don't recommend the keto diet. And then finally, you've probably heard a lot about intermittent fasting these days. And I do think we need more research to know how intermittent fasting might affect diabetes. However, I think it's probably a good idea, if you want to do intermittent fasting, just pair it with one of the diets above. So do intermittent fasting, but eat a Mediterranean or a DASH diet. And then you should be good for helping your body not develop diabetes. Okay. Now we're going to get into medication. So, okay. So, the important thing to remember about medications is that they have to be used in conjunction with diet and exercise. So, all of those lifestyle modifications I just talked about, the weight loss, the diet, the smoking cessation, all of that needs to be paired with the medication in order for it to help prevent diabetes. Okay. And if you happen to find yourself in that pre-diabetes category, so That would be the A1C between 5.7 and 6.4%. Metformin is actually going to be very helpful for you. Metformin's been around a long time. It's cheap. We know a lot about it. We know the side effects. We know how it works. And it can really be helpful if you're in that prediabetes category to prevent you from progressing to diabetes. So if you do have an A1C in that range, you need to talk to your medical provider about going on metformin. Okay. We also recommend vitamin D supplementation for patients with prediabetes. So have your medical provider check your vitamin D level. And if you're low, you're definitely going to want to ask for recommendations on what strength supplement you should be taking. Okay. And then finally, the moment we've all been waiting for are the anti-obesity medications. Okay. So believe it or not, there are various options out there for weight loss. And just to clarify again, so these are for treatment of obesity, which is defined by a body mass index of 30 or more. So if your BMI is 30 or more, you're considered obese, and you would be eligible for some of these treatments. And I think it's important to recognize obesity as a disease process that we need to be treating with medications when lifestyle modifications are failing, because we wouldn't just let somebody with high cholesterol not take cholesterol medications if their lifestyle modifications were failing. We're going to give them treatment. And so I think in obesity, we also need to be proactive in giving treatment. So we're going to spend some time talking about those medications. And the first one here is phentermine. This is something that I typically only use in the short term for about 3 months, just because it does have side effects that can lead to some complications. So phentermine is a stimulant. It is a controlled substance. And so in being a stimulant, it is going to increase your heart rate and your blood pressure. So this is not a medication that you should take if you have a history of heart disease, stroke, or if you're pregnant, because it is going to be dangerous because it will raise that heart rate and blood pressure. It works by suppressing your appetite, and it's actually pretty effective. We found that people can lose about 8 pounds in 2 to 24 weeks on the medication. So I like to use this medication to help people kind of kickstart their weight loss, but it's definitely not something that I want them on for a long time. Okay, so that's kind of the only short-term medication that we offer. And now we're going to talk about more of the long-term medications for obesity. Okay. So the first one, Orlistat, the great thing about it is that it's cheap, but that's where it ends. Other than the fact that it will help you lose about 6.5 to 7.5 pounds a year, which is pretty good. It does have some side effects. It works by excretion of fat through the stool. So if you can imagine, you eat fat and then it comes out in the stool. So the stool is going to be oily and greasy. And some people have been known to have stool leakage from this medication. So, it is a good medication, but if you're having a lot of these side effects, you might not be willing to stay on it long term. The next medication is a combination of phentermine and topiramate. And I cannot even imagine how you pronounce it, but I think it's probably Quizmia or something like that. That medication works on appetite suppression. Oh, and I just want to point out too that the phentermine in this medication, the dosing is much lower than what I would use for the short-term treatment. So it is safer in that sense. But this medication is quite effective. I think it's probably the most effective oral medication that you can get. And people on average lose about 14.5 pounds a year. This is a good medication for somebody who just is hungry all the time and has a huge appetite and tends to overeat. Because what it's doing is it's suppressing that appetite and it's taking away that hunger. So that's a good medication for that type of person. Whereas the next medication, which is a combo between naltrexone and bupropion, also known as Contrave, that medication works better in somebody who needs kind of more appetite regulation. So this is the person who's craving food all the time. They're more addicted to food. They might be eating to self-medicate for maybe depression and anxiety. This medication is going to work well in that person. And sorry, I put a percentage down. People lose about 5% of their body weight per year. So again, if you weigh 200 pounds, you're going to lose about 10 pounds a year. So that's pretty good as well. Both of those medications, the phentermine topiramate and the naltrexone bupropion, can be on the more pricey side. So you're really going to want to look at your insurance coverage if you're thinking about trying those medications. And then finally, in the rectangle there, I've listed the 3 injectable medications that are approved for weight loss. We have liraglutide, which is Saxenda, semaglutide, which is Wegovy, and tirzepatide, which is Zepbound. So these are the ones we're hearing about in the news lately. And I'm going to spend most of the rest of the time talking about these medications. Okay, so the first 2 medications on that list, the Saxenda and the Wegovy, are GLP-1 agonists. That stands for glucagon-like peptide 1. And that is a hormone that is secreted by your intestine and your brainstem when you eat. The medications mimic this hormone in your system and basically helps with blood sugar regulation and insulin secretion. Okay. So what does that mean? So basically, you can see my graphic over here. So the GLP-1 is secreted, sorry, by the intestine to all of these different organs. Okay. So the main one that you would notice if you were taking this medication is the GI tract. It's going to slow your digestion way down. Okay. And in doing so, it takes your body longer to access the blood sugar. So if it takes your body a long time to access the blood sugar, it's going to be hitting the bloodstream a lot slower, and your body's going to be able to manage it better because it's not hitting your bloodstream all at once. Okay. The GLP-1 also signals the brain, and basically it will decrease your appetite. And it also lowers the reward from food that you get. So a lot of patients say to me that these GLP-1 agonists, they quiet down the food noise, so that craving for the food. They don't have as much of an appetite. They're not hungry all the time. So that's that GLP-1 acting on the brain. It also affects the pancreas and increases insulin secretion. So if you have a higher insulin, you're going to be able to lower that blood sugar a little bit better. It also affects the liver over here. It lowers gluconeogenesis, which basically means the liver it can synthesize glucose from foods that are non-carbohydrates. So normally we eat a carbohydrate, our body breaks it down into sugar, and that's how we get energy. The liver also breaks down proteins and fats to get glucose for energy, but the GLP-1 lowers that process, so we're not getting quite so much sugar release into the bloodstream. The other cool thing about the GLP-1 agonist is that it lowers the fatty buildup in the liver. You might have heard of fatty liver disease. Well, these medications can help lower that. So that's a really good side effect. Okay. So this first point that I put down is just to show you all that these medications have actually been around for a while. The first GLP-1 agonist was approved by the FDA in 2005. So we've been researching these medications for, they've actually been out in the community for a couple of decades. The first one was called Byetta or exenatide. A lot of people are wary of these injections because they think that they are brand new and they're injecting themselves with something that we don't know what the long-term consequences are, but actually we do have quite a bit of data on that. So I find that to be kind of reassuring. Okay, and then as I mentioned before, these are the two GLP-1 agonists that are approved for weight loss. The liraglutide or Saxenda is a daily injection, and people lose about 13 pounds a year with it. Whereas the semaglutide, which is the Wegovy, is a once weekly injection, and people lose like 35 to 37 pounds in a little bit over a year. So quite a bit more effective. I did include a picture here. This is a generic pen, but these medications come in pens where you just dial up the dose and then you use a little tiny needle to inject it under the skin. So that's kind of an example of how these medications are administered. Okay. Now, there's one more injectable medication that I want to talk about, and that is tirzepatide or Zepbound. That medication affects two different hormones. Not only does it work on the GLP-1 pathway, but it also works on GIP, which is the gastric inhibitory peptide. This is also a hormone secreted by the intestine that stimulates insulin secretion. So you can see in my graphic, they work kind of a lot on the same systems in different ways. So this medication is quite a bit more effective than the other two that I just talked about because it has two different hormones that it affects. Studies show an average weight loss of 48 pounds in about a year and a half with Zepbound. Although I would say that there is some data where people are losing upwards of 70 pounds in that time. So this is quite an effective medication. Okay, let's see. Okay, so there are lots of other benefits from the GLP-1 agonists. As I mentioned before, they can decrease fatty liver disease, lower kidney disease. They also decrease heart disease, so less heart attacks, reduced hospitalizations for heart failure in people on these medications. So if you have a diagnosis of hypertension or high blood pressure, and you're pre-diabetic or wanting to reduce your risk for diabetes, this is a really good medication to also lower your heart disease risk as well. People on GLP-1 agonists have less strokes, they have better cholesterol profiles. And then they also have evidence showing that these medications lower your sleep apnea symptoms. Sleep apnea is super common up here in Tahoe, and it's nice to know that there is a medication that might help reduce sleep apnea. There's also a lot of promising studies out there. I think every time I open my email, I have a new email about a study of a benefit of these GLP-1 agonists. But the ones that I find to be really exciting are that there shows promise for reduction of addiction with GLP-1 agonists, as well as reducing cancer risk. So keep your eyes peeled because I think we're going to see a lot more benefits down the road. Now, it can't all be good news, right? So most of the side effects from these medications are due to the decrease in your gut motility. So if you think about it, if your digestion has slowed way down, you are probably going to get nauseous, maybe constipated. You might have abdominal pain. You might burp a lot or pass gas. So you can have quite a few GI type side effects with these medications. I have found though that if people are eating small meals throughout the day as opposed to a large meal, they can really mitigate quite a few of these side effects. Also, people can help lower side effects by lowering the carbs in what they're eating and increasing the protein. Patients tell me that when they eat something that is not that healthy, so like a carb heavy diet food or something that's sugary, they really don't feel good. So I always recommend pairing a carbohydrate with a protein, but having that food be more protein than carb. And then just a word of caution, if you are on these medications, you do need to make sure to get enough protein in your diet. Otherwise, the weight that you're losing is going to be muscle weight instead of fat weight. And nobody wants to lose muscle. Let's see. So some serious side effects are listed there. I think, the most common would be like an allergic reaction. We'll talk more about the thyroid cancer risk in the next slide. People can also get cholelithiasis and cholecystitis, which are gallstones and gallbladder disease with these medications. Pancreatitis, which is inflammation of the pancreas, kidney injury, which your medical provider should be monitoring. And then finally, people can get ileus, which is where the bowel actually stops working. It's slowed all the way down to a halt. So I think the important thing to remember on that is that you want to stop these medications about a week before you have surgery, because surgery increases your risk for your bowel kind of stopping as well. And if you have this medication on board, then you're at even more increased risk of having bowel issues like that. So stop these medications 1 week before a scheduled surgery. Okay, so who should not take GIP and GLP-1 agonists? Basically, if you have a personal or family history of medullary thyroid cancer, these medications can increase your risk of developing that cancer. So it's probably best to avoid these medications in that case. The second condition is super rare multiple endocrine neoplasia syndrome type 2. That is a mouthful. Do not take these medications if you have that. And then you do need to use caution if you have a history of pancreatitis or gastroparesis. Gastroparesis is another condition where the gut kind of slows down. Again, it can make it worse. So You can still use these medications, but you have to have a lot of caution with them. And then just ask your medical provider, if you're thinking about starting these medications, if you have any contraindications or anything that you need to take into consideration. Okay, let's talk about barriers to care. So some insurances are great at covering these medications, and then some of them are not. So these medications are super expensive if you're trying to pay cash for them. They're roughly between $1,000 and $1,300 a month. I do know that Zepbound just approved medication vials instead of the injectable pens, which is a little bit cheaper, but still pretty expensive. You can get the first dosing level of Zepbound for about $3.99, I think I saw. But then when you move up in dose, it's $5.49 a month. So still quite expensive. So if your insurance does cover these medications, a lot of times they're going to ask for a prior authorization, which is a medical provider's nightmare. Basically, we have to fill out paperwork and forms and send in chart notes to support the need for the medication. So what I would recommend to kind of help overcome some of these barriers is to be an advocate for yourself and know your benefits. If you're thinking about trying these medications, call your insurance company, find out which ones are covered so you know which one to ask for, and then also ask if a prior authorization is needed. And if so, what information are they looking for? Is it a certain BMI level? Is it the fact that you also have hypertension and prediabetes? If you can gather that information and bring it to your medical provider, they're going to be a lot happier to fill out the prior authorization. And it's probably going to get covered if we are able to put the right information in there. Another thing you can do as an advocate for yourself is to call the pharmacies and find out if they have the medications in stock. Initially, when we were first prescribing these, they were really hard to get, and people, they got the prescription covered, but they couldn't get the actual medication. So I found my patients who call around to pharmacies, they call their mail order pharmacies and know what's in stock, then it's a lot easier for me to prescribe it, knowing that that place has that strength of medication. And then if all else fails, there are the online prescription services and health spas that can provide semaglutide for about $300 a month. Now, this is compounded semaglutide, so that means that it is not regulated or approved by the FDA. And you have to be careful with it because you might not be getting exactly what the bottle is saying you're getting. And then also some of the semaglutide is compounded as a semaglutide salt, as opposed to the peptides, which are used in the prescription medications. The problem with the semaglutide salts is that they can cause your blood sugar to really drop low. Whereas with the peptides, the risk for a low blood sugar event is very minimal. So just keep that in mind and use caution. Okay. All right. So in conclusion, we know that diabetes is a worldwide epidemic, and that prevention needs to be kind of a multifaceted approach. You have to start out with those lifestyle modifications, good diet and exercise that I talked about, trying to lose weight, and then you can add in the medications on top of that to help enhance prevention. And then I did like this saying over here about loving yourself because, you really have to love yourself and take these recommendations seriously so that you can live a long, healthy life. and be around for a while. Okay. Now I'm available to take some questions.
Thanks, Kelly.
Yeah.
I've seen a couple come in, but just as a reminder, if you have questions, you can ask them in the chat box or the Q&A box, and there is an anonymous option if you'd like to ask that way. Um, but the first question I think goes back more to the beginning of your presentation. It asks, how do they test for insulin resistance, and how does that apply to diabetes?
Okay. So, we don't normally test too much for insulin resistance. Typically I mean, there is a blood test for insulin resistance. It's called a C-peptide. However, if somebody is in that 45 and over category and obese and they have a higher blood sugar, we are going to assume that they have some insulin resistance and start them on treatment for that. If the treatment is not working, then we will be prompted maybe to order that blood test and see if somebody can actually respond to insulin or not.
The second question, I'm on thyroid medication, and I will not even attempt to try to pronounce the names, but I believe because of that, I'm not able to take GLP-1s. Is that correct?
Is it levothyroxine?
Yes, I think that's levothyroxine. Yes, and then leothyroxine. I'm sorry, I butchered that.
No, that's great. So those are medications for low thyroid, so hypothyroid. And that does not, having low thyroid does not mean that you cannot be on GLP-1 medications. Um, we are specifically concerned about a certain cancer, so the medullary thyroid cancer, which is not very common. Even if you have thyroid cancer, it having medullary thyroid cancer is even more rare. So, if you have thyroid disease, more than likely you can take the GLP-1 medication.
What about Ozempic? What is the difference between Ozempic and Wegovy?
So, Ozempic is the brand name of semaglutide, which is the same medication as Wegovy. There's no difference, just the name. Ozempic is specifically indicated for a diabetic patient. And you cannot get that covered for weight loss, whereas Wegovy is only covered for people for weight loss and not diabetes. So it's just brand name and which disease they're indicated for. That's the only difference.
Can you clarify the difference between the GLP-1s and the medication that's meant for diabetes? Is GLP-1s taking from the diabetes related medicine?
So yeah, so Ozempic and Wegovy are the same medication, but the Ozempic is for diabetes. Mounjaro and Zepbound are the same medication. Mounjaro is for diabetes only. Um, let's see, liraglutide, which is the Saxenda, I believe is sold as Victoza for diabetes. Did that answer the question?
There's a follow-up, just I think just wondering, I think media maybe earlier on was indicating that people should not be taking this medication for weight loss because it's taking away from medication for people who need it for their diabetes management. So I don't
Okay.
know if you can speak to that.
Yeah, I do think, in the beginning, Ozempic was all the rage. Celebrities were getting it for weight loss, but we're really trying to separate that now that we have brand name medications for specifically weight loss. So if you are obese at this point, you can't get Ozempic covered on insurance. You have to go with Wegovy.
I
That.
think I think that helps. Sorry, just trying to go through.
Yeah.
Um, I'm still I don't know if there's any more coming through. I'll keep an eye. But if you do have a question, make sure to chat it in the Q&A box. And just as a reminder, this webinar has been recorded tonight. So if you want to refer back to anything that Kelly presented on, you can go to our YouTube channel, and we'll also put it up on our Facebook page um, later tonight, probably. And then there'll be a survey at the conclusion once we end tonight's webinar. And we just really appreciate all of your feedback. How did we do tonight? And if there are topics that you would like to see in the future, this was definitely a topic that has been brought up in previous surveys. So we really do appreciate the feedback and our listening. So I think that's it for what I see coming through. I just really appreciate you being here tonight, Kelly. Thank you for the great information and presentation. And thanks for everyone for joining. I hope you have a good rest of your evening.